The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health Podcast. Today, I have with me Dr. Jamie Litvack. She is a board-certified ear, nose, and throat specialist in Seattle, Washington, providing comprehensive care for patients of all ages. She treats a wide range of conditions from ear infections and hearing loss to voice, throat, sinus problems with thoughtful, patient-centered care. She's fellowship trained in rhinology, and Dr. Litvack has advanced experience in managing complex sinus and nasal issues. And I sat next to Dr. Litvack was that 2 weekends ago now at a business conference, and we got to talking about menopausal symptoms that we see in ear, nose, and throat. She was super curious, so I asked her to come join us to talk about these particular issues and enlighten us with what's going on. It's not just a dry vagina. We've got dry ears. We've got dizziness. We've got a dry mouth sometimes, dry eyes, hearing changes, and ringing ear. As well as some patients are complaining that they got this stuffy nasal congestion going on. So welcome, Dr. Litvack.
Thank you. Excited to be here.
Yes, thanks for joining me. Okay, so we are going to dive in because you see these symptoms all day, every day. And you were asking me a lot of questions about menopause and how it kind of relates. So I'm curious if you're starting to see this more in your practice in women in midlife.
Absolutely. I think there's a lot of symptoms we see in the ear, nose, and throat area that we see in women in midlife. But strangely, we don't have a lot of data for it. So we're still learning a lot about how this affects our patients.
Right. I mean, we can't say that it's necessarily linked to this, estrogen deficiency, but we know that we have estrogen receptors throughout our body. So it makes complete sense. It's not just hot flashes and night sweats and vaginal dryness.
And absolutely. And some of our body parts, we just can't even biopsy, right? If we tried to biopsy the inner ear, we would go deaf. So it doesn't work.
Fair point. Fair point. So we don't know how estrogen receptors, kind of in the ear canal, like we can't really test that. We don't know, but we're seeing more dry ears, itchy ears. So talk to me about how this kind of plays out, because you had a really cool solution.
Yes, I see a lot of the medical term is called otitis externa. But if you think about when you were a kid and you maybe had swimmer's ear and you either had that itchy or that pain, this is sort of the adult version of that. Something in the ear canal that you just kind of want to scratch or you want to put a Q-tip into. And that area can be very hard to really see, right? You can't see it yourself, but it can have a lot of sensations tied to it. And we know that with hormonal changes, we don't actually have estrogen receptors in our outer ear, but we do get these changes in our skin quality. And we can see a lot of dry, itchy ear. It can even feel like something's crawling around in there. And again, you may want to stick a finger or a Q-tip in there. So lots of strategies. We actually see kind of mostly that dry skin, but also sometimes people can have super moist skin. If you have that super dry skin, something as simple as mineral oil can be put in there just to keep it moist. You can do that a couple times a week. Pretty simple, pretty straightforward. There's a fabulous medication that I like to use for people whose itchy ear has gotten much worse, and it's called Lotrozome. It's actually over the counter, and it's even marketed as athlete's foot. But it's a combination of a steroid and an antifungal. So the two terms for that are the antifungal is called clotrimazole and the steroid is called betamethasone. But you basically want to put a pea size on your fingertip, put it in the outside of the ear and just kind of around. You don't need to stick it in deep. Do that twice a day for 2 weeks. And that can really break that cycle of itchy ear. It's really important not to put Q-tips in there. Super, super important. We can talk about that in a second. But what I like to do for that itchy ear is put the pea size in twice a day, 2 weeks, then take the medication, put it on your shelf. And the next time you get an itchy ear, you can do it again. So, for example, if you're someone who chronically has problems, you just know that you will, you could use it twice a week. But if you're somebody who's fine for several weeks or months at a time, just put it in your drawer and bring it back out in a couple months when you get that itchy ear again.
And so did you say it was daily or twice daily for 2 weeks?
Twice daily, 2 weeks. And we're really just trying to break that cycle.
Sure. And what are they looking for specifically in the pharmacy again?
It's called Lotrizone, Lotrisone.
Okay, just want to make sure everybody knows what they're looking for.
Lotrizone. Yes.
There's plenty of people who are seeking that. Okay, and then
Also, sorry, one other thing. Q-tips. The Q-tips are, they keep me in practice. They keep me very busy, but they're so tempting to use. The challenge is that, especially with dry skin, is that they make these little micro abrasions, these little micro cuts in the ear, and those can get infected, especially if you have any other underlying issues like diabetes or something else that could put you at risk for infection. So we really want to try not to put those in our ears.
Okay, that's why we don't use Q-tips. All right.
And of course, if none of this works, make sure that somebody looks in your ear and make sure it's not something else going on.
Right. Right. That's a fair point. If it doesn't help, then we need to seek professional help. Okay. So on to hearing changes and the ringing ears or this tinnitus.
Right. So there is some interesting data out there that does show that we do have estradiol receptors in our inner ear, and that our levels can influence the sensitivity to hearing. So we actually think that women going through menopause may be losing more hearing during that time period. Again, we don't really understand much about this, but I do think that's interesting. And one of the clues of hearing loss is tinnitus, which you might hear the word tinnitus. It's spelled Tinnitus. It just basically means ringing, and ringing doesn't necessarily have to sound like a ring. It can be a high pitched he, it can be more of a shh, but it's oftentimes a clue that there is damage to the inner ear. And so I think of the inner ear hair cells they're kind of like dancing in the wind without the music playing anymore. And so they're kind of giving the brain clues that, hey, I'm not working as well as I used to. So if you get the ringing in your ears, the first thing you want to do is make sure that you don't have actual hearing loss. There are a couple types of hearing loss that are really important to identify sooner rather than later, especially, for example, if you get it in one ear but not the other. We want to know about that sooner rather than later. There are some treatments that are time dependent. But in general, if you're getting it in both ears, it feels the same on both sides, or you hear similar sounds. The first thing I would say, it's probably a good idea to get a hearing test. And you can go to your local Costco and they'll do it for free. You can go to your doctor and see if there's someone that can do a more formal test. And again, we're just trying to look for clues that something isn't working as well as it used to. The second thing about tinnitus is that it's very sensitive to people's perceptions. So, for example, you can have two people who have the same amount of hearing loss and the same amount of tinnitus or same amount of ringing in their ear, but one is really bothered by it. They can't sleep at night. It's very anxiety producing. And the second person is like, oh, yeah, I knew about it. I kind of ignored it and I moved on. I often tell my patients to try strategies for appreciating that the brain is basically setting off the alarm system and telling me, hey, I can't hear as well as I used to. But my mind can tell my brain, like, yes, thank you for setting off the alarm. I appreciate it. Okay, let's move on with our life. Or the mind can get very fixated on it and say, this is driving me nuts. I just don't, I can't sleep. I don't want to do anything. It's very anxiety producing. And so just being aware that, hey, this is a clue that maybe I'm not hearing as well. Let's go get that figured out. And then acknowledging that can be very, very helpful. Because I say it's one of those things that either you will get a hold of it or it will get a hold of you. Um, so first things first, get the hearing test. But the other things I like to do for strategies are camouflage in the background. So any kind of noise or sound that sounds like the sound in your ear sounds very counterintuitive, but actually playing a sound in the background can help alleviate the symptom or the severity of it. If you ever think about some of your older family members when you were a kid that always had the TV playing in the background, one of the reasons was just to kind of alleviate some of this ringing in the ear. The second is that we see that people who are, or I tell people that in some ways it's almost like a thermometer for stress in our lives, because oftentimes tinnitus will get worse when you're feeling stressed. And when you bring that stress back down, you can actually get it to be less bothersome. There's actual studies out there where if you take two groups of people and one does intense meditation and yoga and another does nothing, that the patients with the meditation and yoga can actually bring their tinnitus much further down. So there's a very interesting, we don't fully understand it. There may be something about the way that our body responds to, cytokines or inflammation or whatever that we just don't know. But really that stress reduction is super important for bringing it back down. Doesn't mean it's going to go away ever. And then the third thing is we do have things like hearing aids with software that include masking devices. So you can actually decrease the kind of the severity of the symptoms. But number one is just getting that hearing test.
And so do we think that it's more related to hearing loss, or what do we think the underlying cause is?
Well, tinnitus in general, I tell people, is a symptom of hearing loss or hearing damage. So sometimes
Mhm.
you'll have ringing, but your hearing test will be normal. And so there's a suspicion that maybe there's a little bit of damage to our hair cells. So if you think about the inner ear, there are these very, very cool hair cells that they can take a number of hits throughout life, right? You go to a loud concert, the next day you can't hear as well, but 2 days later you can hear again. That's fine, right?
Mhm.
So our body's really good at healing itself, but eventually the damage catches up. This is why we're so big on protecting our ears from loud noises, using earplugs if you're going to be around loud sounds. If you're going to a concert or mowing your lawn, like plug your ears. Let's kind of keep the noise at bay. And our ears can handle some number of traumas, and everybody's a little bit different. Genetically, some people are designed to be able to have more damage and other people less. But if you think about it, you've had all these loud noise exposures over a lifetime. Eventually, it catches up with you. And we're just really trying to keep, so you could have a little bit of ringing that's a clue that there's some damage. There's not hearing loss yet. And so that's a good sign that you should just protect your hearing.
So that's when it's reversible, but then at other times you're saying that it's probably just we're treating the symptom.
Yes. The other thing that's interesting about the brain is that, again, I think of tinnitus as setting off the alarm system. The brain can learn to be not as interested in telling you. Like, so the alarm system can be quite loud and then it can turn itself down.
Mm, interesting. Okay. Fascinating. All right, now we're going to move on to that vertigo or dizziness that we experience in midlife. Can you talk to me a little bit about the inner ear structures and how that's involved in that balance?
Yes and no. I think, vertigo is, we talk about vertigo as kind of this like room spinning sensation, although either self spinning or room spinning. But some patients come in and it's more like just this sort of disequilibrium or not feeling quite balanced. And so that's oftentimes what we call vertigo, which is very similar to the idea of dizziness. I will say there are so many reasons that someone can feel dizzy, right? You could have uh, electrolyte abnormalities, you could have medications that are influencing it, you could be sleep deprived, right? There's so many different reasons. So I really focus as a otolaryngologist on the ones that are in the ear, nose, and throat area. And it's really kind of, we call it peripheral vertigo. There's really about four common things that we see that cause that dizziness. One is the crystals in the inner ear just kind of being misplaced. And so if you've ever heard the term of, it's a really big one, called benign paroxysmal positional vertigo. But if there's crystals in your ear that are dislodged, that's a really nice, easy one to solve. So if you're somebody who, when you lay down at night and you turn to the side, all of a sudden you feel the room spinning and it lasts about 90 seconds and then it goes away, or you turn to the other side and it goes away. You may have something called this, the crystals might be in the wrong part of the inner ear. This is generally very fixable. There's some exercises that you can do that just reposition the crystals in the inner ear. It's very, very fixable. Oftentimes we just see it kind of randomly. You just, again, you're minding your business and then you start noticing these symptoms that last seconds to minutes. Sometimes you'll get it after running. Sometimes you'll get it after a fall. Sometimes you'll get it after a car accident. Sometimes you'll get it after a roller coaster. But honestly, you could just be going about doing your day-to-day activities and something gets repositioned. I mean, the one that I think of mostly is like a runner, right? They went for a run, they came back, and like now they have this dysfunctional dizziness that lasts seconds to minutes and is particularly noticeable when they change head position to one side or the other. The trick for this one is called the modified Epley maneuvers. We basically work through, and you can do this with, you can do this at home. Honestly, you can look this up on YouTube. And basically you're repositioning the crystals in your ear. Your ear, nose, and throat doctor can help you with it. Any kind of balanced person, a balanced therapist could help you with this. You can literally do these exercises, home exercises, 3 times a day. They take less than 2 minutes, and you're really just repositioning the crystals in your ear. It feels really weird at first, and sometimes people are hesitant to try it because their symptoms get worse rather than better first, but that means you're doing it right.
Okay.
And it should get better in a couple of weeks.
So a couple of weeks, we would expect it to get better.
Yeah. So it's called, so they're called modified Epley maneuvers. And they're also very fatigable. So if you did the same exercise 3 times, it should get better every time. Like, so again, people don't want to do it because it feels bad, but as soon as you work through it, it gets better. So you get positively rewarded for experiencing the problem. So yeah, that's a very fixable one that we see a lot of, and you can fix yourself on that. Then there's a couple of other kinds we can talk about too. Vertigo that lasts minutes to hours. We think about other symptoms like, is it associated with ringing in the ear or changes or fluctuation in your hearing, or ear pressure? There's a special kind of disease called Meniere's disease that we see.
Yes. I have a
And
pig struggling with that now.
okay, yes. And that one can last hours. So that's room spinning that lasts hours. And again, you may notice loud ringing, pressure in the ear, not being able to hear as well during that time period. If you got a hearing test, you might have a fluctuation or a temporary hearing loss on that side. That one's treated very differently. There's the biggest thing and the most important thing is a low salt diet and seeing how that works for you. And when we say low salt, we mean low salt. That means basically fresh fruits and vegetables, no canned foods, no soups, nothing else. And that's first line, but we do have medications for that as well. And that you will probably need to see an ENT to work through with you. And then the third one that we see is called vestibular labyrinthitis. And this is like one where you just feel so sick. The symptoms last 4 hours. You really do want to throw up. You're nauseous. You may go to the emergency department. You may get admitted to the hospital even just because you just feel horrible. And after 5 days or so, you'll feel better. So oftentimes these are patients who feel so miserable that they are in the hospital getting IV fluids. Not as common. You'll know it when you have it. And also it tends to self-resolve. And so you're not going to see that kind of recur again. The fourth one that we see it a lot more than I think we realize is one that's called vertiginous migraine. And so people traditionally think of migraines as being something that involves vision changes and a headache. But in fact, you can actually have no vision changes, but just have this room spinning vertigo that lasts hours at a time, is triggered by similar things that that migraines would be triggered by, whether it's, you know, the same things. I don't know how much you've had talks about migraines, so that could be another conversation in and of itself. But whether it's triggered by stressors, being tired, foods, whatever it is for you. You can get this like room spinning vertigo that lasts hours. You just want to lay down in a quiet room and take a nap to get rid of it. And again, it doesn't have to have a headache even, but you certainly don't have to have the vision changes. And so I think that's the one that maybe we probably underdiagnose, right? You have people who like have this miserable dizziness that lasts for hours, really does affect their ability to work that day or just get, through life, recurs. And anyway, so migraine is another option that could happen.
Interesting. I've never considered a migraine without a headache, but you're saying that this could definitely be related.
Yes, and I suspect that one, I think hormone related would definitely factor in, right? Because if we know migraines would be influenced by this, I would say vestibular migraine should also have issues.
Yeah. We definitely see a shift in migraine headaches in perimenopause and menopause for sure, and supporting with hormone therapy typically.
Can you tell me a little bit more about that, like what you see?
Yeah. So with the rapid fluctuations or the random fluctuations, erratic fluctuations with estrogen levels specifically in perimenopause, sometimes we'll see migraines worsening, and sometimes they improve in menopause whenever that's kind of leveled out. But oftentimes with hormone therapy, can see with proper hormone therapy, we can often see that their migraines actually improve.
So I would pay attention to vestibular symptoms then related to that.
Hmm.
Yes.
Yeah. So let's talk about this rhinitis or the stuffy nose, runny nose. Are you seeing runny nose? I'm hearing patients more often tell me that I've had like two in the last week. And I'm like, really? That's interesting. Saying that they just feel so congested. And, we see this in pregnancy because we have an increase in blood volume and there's increased vascularity to that so that they experience that nasal congestion, but this is a new one for me, having a couple of patients recently mention that.
So there are estrogen receptors in the nasal mucosa, right? I'm a fellowship trained sinus surgeon, so I spend a lot of time thinking about stuffy nose. And there are many reasons you can have congestion or stuffy nose. And some of those can be related to anatomy, right? So the nose has got this very sort of three-dimensional anatomy. And as we age, even our sidewalls tend to not be as durable. So we have these cartilages in the sidewalls that can collapse or just kind of not be as resilient as they are when we're younger, or you get damaged through life. So there can be anatomic changes, even septal deviation. So if you think about the cartilage in the middle of the nose, that is not perfectly straight in most people. And I noticed that as we move through life, that sometimes that shifts a little bit. And honestly, just a couple millimeters in the nose makes all the difference to your ability to breathe. So if you think about something shifting a couple millimeters, that can make the difference between breathing clearly and feeling like you can't breathe at all. So anatomically, there are reasons our nasal valves, our cartilage, our septum, those things can contribute to stuffiness or congestion or inability to breathe. There's also along the nasal mucosal membranes, especially this time of year, allergies are acting out for a lot of people. So, sometimes people will, I know at least where I live in Western Washington, it looks like somebody just opened up a pillow and spread it across the sky. There's like so much pollen in the air, and that can really, even if you don't technically have allergies, you just feel so congested from all these things in the environment. So that can contribute to things as well. I have a couple strategies for you to help through this nasal congestion or stuffiness. There's also kind of the flip side to this where I see a lot of people who have runny nose or drainage in the back of their throat. And so some people will say runny nose, some people will say postnasal drainage, some people will just have this like thing in their back of their throat that they can't clear. Um, Sometimes when I talk to patients, they will say, I don't have a runny nose because it's not coming out the front, but they, are sniffling all day long and it's going down the back of the throat
Mhm.
instead. Same issue is just going a different direction. Some people will end up literally carrying a Kleenex box with them around all day long because they just have so much drainage that they need to clear. And it's not just about the allergic rhinitis. So sometimes people think it's allergies, but there's also other reasons for it too. We have a nerve in the back of our nose that actually, it's called the posterior nasal nerve, and it can trigger some of this mucus. And actually, some interesting piece of trivia, we all make a pint of mucus a day.
Right.
So we all make a pint of mucus a day. You don't usually notice it, right? But some people do. And so part of that has to do with, this posterior nasal nerve, and maybe it's a little bit hyperexcitable. And we have strategies for dealing with that too. So we can talk about, different strategies for different parts of the nose as much as you want to.
Yeah, I mean, fill us in. So for the stuffy nose, what are your strategies for treating stuffy nose? I mean, and we're assuming like we don't have a upper respiratory infection or a sinusitis, an infection of any sorts, right? This is just like this chronic
Congestion that's been
sensation of
going on.
feeling
Yeah. That
congestion.
you've
Yeah.
noticed over the last couple of years. I will say if you notice new congestion and you're getting nosebleeds, particularly out of one side of your nose, and you just can't breathe as well as you could before, you're getting anything that causes tingling, numbness in the face, changes in sensation. All of those things need to be seen by a specialist, right? We want to make sure we're ruling out unusual causes. But by and large, most of these are not unusual, concerning issues.
Right. Right. Okay.
So, yeah, as a tangent, like you've never had nosebleeds before, but all of a sudden you're getting them, they're getting frequent, you're going to the emergency room, you're not sure why. Like that's something that an ENT needs to see you for.
Sure.
But for congestion, things that I really like, kind of just good hygiene, as I call it, good nasal hygiene. I love saline irrigations. So we talk about something like
Okay.
Neti Pot or the NeilMed rinse kit. So NeilMed spelled NeilMed. You can buy it on Amazon. It's at every drugstore. I think a lot of drugstores have their own generic version of it. It's literally like a squeezy bottle with a tip, but it works well. Um, it comes in kind of three flavors. There's the high pressure, low pressure, and the intermediate pressure systems. And the idea behind all of them is that you're using a high volume of saline irrigation to flush the inside of the nose. So it's like giving the inside of the nose a bath. High pressure systems you might hear about are like the nasal lavage system. It looks more like a water pick. I really discourage people from buying that unless they really need the high pressure. I feel like it's overpriced. Like it's just frustrating to me to see how much money they're charging for this system when I know that the medium pressure system works just fine and is substantially cheaper. The low pressure system is the traditional teapot, which you may have seen, and can be somewhat awkward because it is a teapot, right? Like, how are we getting the teapot, in our nose and around the sides?
The
But
ergonomics just don't make sense.
and yeah, that's an interesting one, right? And that one's been around for 4,000 years, more or less, right? So this idea has been around for a long time. The big things are you want to use salt water, not fresh water, right? So if you just used water, it would burn. It burns. You want to put salt and baking soda in it. And again, they sell these as like simple packets at the drugstore, like 100 for $5 or so. That is a lot easier to make it pH balanced, so it's more like ocean water instead of lake water. Super important. You want to use boiled or bottled water. So if you buy bottled water off the shelf, it's safe. If you brought, if you distilled water that someone might use for CPAP is safe. If you're going to use tap water or well water, you have to boil it first and then cool it down. Brita filters do not count. So it really does need to be filtered water. And then put the salt packet in to make it pH balanced for the nose and lean over the sink or in the shower, squeeze half on one side, half on the other. It'll come out the same side, the other side of your nose. So one side of your nose, the other side of your nose, or out your mouth. All of that's normal. They're all related to each other. And I think of it as giving the nose a bath. So it's a really great way of just getting rid of extra irritants that are in our space and our environment. And then after that, I apply a medication. And the medication I usually like to start with is something like fluticasone, which is Flonase, or triamcinolone, budesonide, any of the nasal steroid sprays that you can get at the drugstore. These all used to be prescription only, but now they've been approved for over the counter. They come in brand names like Flonase, Nasacort, Rhinocort, but the generics are perfectly good. No one is better than the other. They're all kind of cousins of each other. And so one works better for one person, the other is better for somebody else. The super important point to remember is they're very, very mild. And people get very worried when they hear the word steroids, right? Because we know we're not supposed to be taking a lot of steroids, not good for our bones or our calcium or, our blood sugars or renal function. And this is one that is very mild. It's absorbed in the nasal mucosa. What I love about it is it's not systemically absorbed in the way that a pill would be. It's certainly not a muscle builder type of steroid. You can use it for years at a time, but you do need to use it every day for a good month to see if it works or not. So it takes a couple of weeks to get to therapeutic dosing and then another couple of weeks. So 4 to 6 weeks, try Nasacort, Rhinocort, Flonase, see if that helps. And for a lot of people, that's all you need for that stuffiness. And I think that's kind of the first line. There are a lot of other options out there, so we can keep talking about all of those too.
Let's move on to the runny nose. And what are your easy tips for runny nose?
Runny nose. Runny nose, I
Or the
like, there's two
postnasal
nasal,
drip, you're saying?
yeah, the nasal drip. So I
Yeah.
like 2 sprays. There's one called azolastine. It can taste really funny to some people. It is a prescription level. It's called Azelastin, I believe, azolastine. And it's a spray that can help reduce that runny nose twice a day. There's another one called ipratropium bromide nasal spray. And that one you can take 3 or even 4 times a day. It tends to be shorter acting, so it works for about 4 hours. So let's say you're somebody who, like, every time I eat breakfast, I get this really bizarre runny nose and I need to use the Kleenex, then try something like the ipratropium. So some people do great with those for the runny nose. The other thing that we have some devices for that is a kind of like a one-time solution, which is nice, is ways to reduce the activity of the posterior nasal nerve itself. So it's an in-office procedure. We have a couple of different mechanisms for treating it, but we can basically either freeze the nerve in the back of the nose or with cryotherapy, or we can use something called radiofrequency ablation, which basically is a way of reducing the activity of the nerve. It takes about 6 to 8 weeks to work, but has been really helpful for a lot of people just to turn down that leaky, like, runny nose that just doesn't stop, and to keep you from having the Kleenex, constantly at bay. There is, of course,
Interesting.
yeah, of course, there is a situation of, like, the leaky faucet that never stops and that you need to see the ENT for.
Yeah. So I think what I'm hearing here is that there's so much, it's so multifaceted. There's definitely a holistic approach to take to this. I never knew that we could talk about ENT stuff this in much detail for this long. And it sounds like you can just keep going. So if you have problems that remain unresolved, despite the fact that you're on your hormone therapy, maybe you're completely stable on your hormone therapy, but you've got these lingering symptoms or nagging symptom that just hasn't gone away, it's probably just time to see an ENT to make sure that we have ruled out anything more concerning.
Yes, and, one of my favorite parts of ear, nose, and throat is that it's about quality of life, right? So if
Uh,
something isn't working for you, please come see us because we have options. We have lots of
yeah,
options.
I love it. Okay, well, this has been some fabulous recommendations for symptom relief for patients and just being aware of when to go see an ENT. I can't thank you enough for joining us today. If you are dealing with symptoms that no one is connecting to menopause, you're not imagining it. At Sky Women's Health, we specialize in identifying and managing a full spectrum of menopause related changes. And you don't have to navigate this alone. So please check us out, skywomenshealth.com. Share this episode with a friend. Leave us a review. If you're a physician, physician assistant, or nurse practitioner who cares for women and is uncertain about how to help women navigate menopause, I have a menopause masterclass. And you can find more information about that on social at Dr. Carolyn Moyers. Thank you, Dr. Litvack, for your insight. Where can they find you?
I'm at Western Washington Medical Group in Everett, Washington, and you can find me on LinkedIn and through our website.
Okay, so we're not on the social channels yet. That's our next step, huh?
That's right. That's right.
Okay, fantastic. Until next week, be well.